Well, good morning, everybody. What a privilege it is to be here with all of you today for the Crisis Jam, Wednesday, April 13th. We have actually several incredible speakers today. Only one featured here on the front slide, but you're in for a real treat today. So I'm really looking forward to our conversation as we move forward. Next slide. So today we have the privilege of having Dr. Chuck from RI International and Dr. Rob Cotes from Emory University, who are going to lead us through a conversation around the role of medication in crisis facility care. I'm really looking forward to that. It's coming right up in just a few minutes. Next slide. So all of our states, one thing that I was told this morning that I'm super proud of is that for the last several months, we have been adding 4 people to the newsletter every day. So that's just, let's keep that up. Invite your friends who are working in this area or others who are just sort of adjunct and interested in this. Also, if you're from a state that's not lit up in red, but include Medicaid, please let us know so that we can make sure and add you to our state slide here. Next slide. So if you are wondering, you missed last week or the week before, and you're wondering, how can I listen to that? Remember, you can always go to our website and listen to the recordings. You can also sign up for weekly reminders that let you add it to your calendar. And also our website now has a new tab for the calculator. So I know a couple of you heard about the calculator. Maybe you heard a talk at NatCon last few days about the calculator. We all know it's exciting. We're going to have the data corner today. So make sure and visit the website for any of your needs around our learning community. Next slide. So one news piece we wanted to point out today, and we're going to have a speaker in the next few weeks about civilian crisis response, a toolkit for equitable alternatives to police. And I'll just say, I had a chance to look at the toolkit this morning, and it's anything from hiring to recovery-oriented language, to mobile crisis, to data, to funding. There's everything in this toolkit. So if you have a chance, Google the Civilian Crisis Response Equitable Alternatives to Police, take a gander at it. And on May 4th, I want to say, we have a speaker on it. So I'm really looking forward to that. Take a gander at it ahead of time. Next slide. So we loved this quote from the governor of Ohio, Mike DeWine. This was part of his State of the State speech. And he said, "My friends, the system isn't broken. It was just never fully built. And it doesn't exist everywhere in Ohio yet. And so we must build it." And I know that this quote must resonate with many of us on this call who are part of building it in their own state. And we thank you for it. And we love the fact that every week we can come together and learn from each other about how to leverage the expertise in other states for our own state and for the people that we serve. So thank you to everybody on the call, and thank you to Governor Mike DeWine to really putting words to what we're all doing together. Next slide. So I have the immense pleasure of introducing 2 people who I really admire to have a conversation today with us and to allow us to be observers of their conversation. So first, I want to introduce Dr. Rob Cotes. He's Associate Professor at Emory University in the School of Medicine. He's also on the clinical expert team of SMI Advisor. And lastly, he's very involved at the American Psychiatric Association in leading what we're doing at our annual meetings and topics that we should be discussing as a community. And of course, Dr. Chuck, an old friend of this call, been here many, many times, and we so appreciate his work as CMO at RI International. So I hand it over to the 2 of you to let us peek in on a conversation between the 2 of you today.
Thank you so much, Amy. We've been having a good conversation in preparation for this conversation to share in the learning community, and it's been really enjoyable. I'm looking forward to getting into it. So as a learning community, we've been covering many facets of how to maximize effectiveness as we develop and implement crisis systems nationally. So how do we look to design and create systems that serve everyone with access and good care? So today I have the privilege of having this conversation with Dr. Rob Cotes about how medications fit into this system, specifically at crisis care facilities, which are serving others in crisis. So Rob, let's dive into this.
Yeah, sounds good, Chuck. It's really great to be here. Thank you so much. So maybe to get things started, I'm curious, Chuck, what are some general considerations for conceptualizing the role of medication in crisis care? Maybe we can organize it into the whys, the whats, and the hows. So first, why do we need medications?
Great question, Rob. So as we've been talking in our discussions leading into this, medications are an important tool. They're one of many tools that we use in crisis care, but definitely not the only. Meds can be a helpful tool to be able to say yes to everyone coming to your facility in crisis, but they can also be part of best practices where they can offer better care with relief and possibly symptom improvement, especially when combined with other crisis care therapeutic tools. We have guests present with just a myriad of different things that are parts of the reasons why they may be presenting in crisis. So when you're thinking of symptoms, and it's not always about symptoms, but when you are focusing on symptoms, it can be things like suicidality, really distressed sleep, depression, mania, psychosis, trauma, substance use, and other concerns. Sometimes they come into facilities voluntarily, and sometimes they're coming in involuntarily against their will. In some of those cases, guests may have really severe agitation, and at times cause them to be at such levels of agitation that they may be at imminent risk of harming themselves or others. That could be related to mental health challenges or substance use effects like intoxication or withdrawal. It also could be related to other things, medical causes, medication side effects that they're dealing with, or substance use intoxication or withdrawal. So guests often present for short-term stays in crisis units of several days. And one other thing when you think about medications is not just for mental health or substance uses, they may have needs for basic medical care, things that they're dealing with related to blood pressure or diabetes, an infection in their skin. And if you can't manage that at a facility separate from a hospital unit, then it's someone who you can't create access to care to because they may have to have that need covered first.
Yeah, I really like the emphasis on the holistic approach. And the notion that medications are a part of the treatment plan and certainly not all of it. So to get a little bit more into it, what medications do we need?
So when thinking about medications, Rob, and we're talking about using them as a tool, you do need to have meds readily available for the mental health needs and substance use needs that we mentioned above. So for best practices, you need to be able to have a range of medicines to help support symptoms that are part of the holistic approach to doing that. I think about with substance use, for best practice and being able to support their folks' needs, we do have some situations where people present in potentially medically dangerous withdrawal with substances like alcohol and benzodiazepines. So you need to be able to have a combination of medicines that are best practice to help keep that person safe and manage withdrawal. For folks who are presenting with opiate use disorder, being able to continue their medication-assisted treatment can make a big difference in being able to give them access to care. If they're there for psychosis, but also are on methadone and at 100 milligrams and you stop that suddenly, there's going to be a lot of challenges and problems with that. And so being able to do that. And now best practices in mirroring what we're doing in medical emergency rooms is being able to do inductions with buprenorphine, which is a best practice in care for opiate use disorder. And then finally, like I talked about, needing some basic medications for things like blood pressure, diabetes, certain basic antibiotics, basic medications for pain, and so forth. Finally, I'll give out a shout out to Dr. Margie Balfour for one of my favorite slides of hers when she in a slide deck talking about agitation and managing agitation in crisis centers. And it has a graph and it's based on a study of looking at different medications and how well they help with agitation. And as you look at the graph, the line goes down and you're guessing what medication that was so much more effective than these other ones, and people are throwing out different psychiatric medications. And guess what the medicine was, Rob?
Nicotine patch.
Exactly. So it's an important medication to have available for comfort if you're a non-smoking facility and someone's going to be there for several days and have that suddenly stop. So it's a really important not to forget.
Such a great point. Tell us a little bit more about how we should use these medications.
So I'm going to go over just some very basic general concepts about medications, but then I'm really excited to ask you about some specific hows and your level of expertise as we go through that. So one of the first ones is a focus on collaboration about medications with persons being served. I have the privilege at RI of working with so many amazing teammates and friends with lived experience who have often been persons served in crisis themselves. And I cherish, Rob, their sharing of their experiences of seeing a psychiatric provider for medications in crisis. We as providers just have such a powerful position. It's a position of power in these moments of crisis when guests come in. And oftentimes guests don't feel empowered to talk about their concerns related to medications and truly be a partner in their care. If you think about it, a lot of times we're also, the provider is the one making decisions on whether the person is going to go home if they're on involuntary commitment or not. We also sometimes have prescribed, you can get to a situation where you prescribe medications that can cause someone to be sedated and not maybe be able to think as clearly about being able to talk about what they want to do and things like that. So we have to be really aware of that. And we have a saying about collaboration that's in crisis that it's important to do with and not to. And it's so easy to get rushed in working with those that serve in about what they want from their medicines and not be able to create an open, engaging environment that's a shared relationship of talking about, what are your concerns about your symptoms? What are your side effects that you're worried about? Do you have to, a question folks ask all the time, but sometimes they're scared to ask in crisis is, do I have to take this forever? And those kinds of things. So it's a really important piece. Going along with that, another recovery-oriented approach to looking at this is understanding that, like we talked about, medicines are just a tool. They're a tool for crisis care, but not the only tool. And so understand that there's so many other factors that can be an important part of why somebody is presenting to crisis than just their symptoms, social and economic determinants. But if your crisis service only involves developing a psychiatric diagnosis and then having a medication for the approach to that concern, clinical outcomes are going to suffer and people are not going to feel as cared for. They're not going to feel empowered. And I think you'll see more time for their crisis to resolve and potentially a more traumatizing experience. Another big one is we have an opportunity in designing these systems now to create an inclusive approach by developing crisis guidelines for medications that embraces voice in the co-design from lived experience, families, folks with IDD, BIPOC, and other communities that haven't often been as included in the dialogue of designs. And so as we shape our systems, can we assure that we, for example, evaluate racial bias and effects on diagnosis and prescribing practices that we know happens? And then finally, as wrapping this all together is, we want this to be parity to emergency medical services. And so we have certain known guidelines are developed based on years of research and data and management systems that we use universally across the emergency medical system. And we need that same type of approach in training, monitoring tools, systems that we use to develop and research, speaking with Matthew's corner that he's going to talk about later, research to drive on what works and what doesn't work and continue to develop that in a continuous quality improvement mode. So that's the general, Rob. Now I want to talk about some specific things with you and pick your brain on your expertise in some of these areas. So one of the things that we often see at our crisis centers is guests who are coming in who have a first-time episode of psychosis or they're very early in the time that they're having those symptoms present. Can you talk a little bit about how you think about medications in those contexts and what are some of the best practices for that?
Yeah, absolutely, Chuck. I mean, based on the general principles that you talked about, some of the key words that stood out to me were collaborative, recovery-oriented, inclusive. And, the collaborative part is so important, I think, not just with the person that you're working with, but sort of with the community more broadly. So before we even get to medication, with people with early psychosis, one of the first things I'm thinking about is, might someone meet, eligibility for a coordinated specialty care program where they can actually receive wraparound services that are person-centered, and they can really, I think, get, some of our best evidence-based treatments. And there's some really great treatment locators available at PEPNet and at SAMHSA. So we're going to be throwing some links into the chat here that are going to be coming pretty hot. So just people be aware that there's going to be some links coming, some from SMI Advisor, then some from other places. But when working with people with early psychosis, the principles of the pharmacology are often pretty straightforward. So for example, we often encourage prescribers to use about 1/3 to 1/2 less of the dose of medication than someone who's experienced psychosis for a longer period of time. But the application of the principles can be a little bit more complicated. And the real art, especially in a crisis setting, is to be able to develop a therapeutic alliance in a short period of time and help to explain to a person going through what might be a very difficult experience, what the medication is for and why it might be helpful. So simply just saying that this medication might help you sleep or this medication might help you calm down, that can erode the culture of trust that we're trying to cultivate. I might ask somebody if they've ever heard of psychosis and might provide some gentle framing around the idea. I keep in mind that even when you're explaining things, that there's two experts in the room, sort of, some of the things that Dr. Deegan often talks about. So when choosing a medication, for someone experiencing psychosis for the first time, there's often many, many good options. And some of those options might include medications with a lower risk for cardiometabolic side effects, like aripiprazole, ziprasidone, lorazepam, cariprazine. Choosing a medication with significant cardiometabolic side effects like olanzapine might be less recommended. So one of the things I like to do is often present multiple options to a person and then let them make the decision for themselves. And some of that might include a description of what some of the side effects might be. And then, really sort of encouraging people to pay attention to what they experience and using their own expertise to help guide us as prescribers. So we have a couple of reviews for prescribers working with individuals with early psychosis that are going to be coming in the chat. The other thing that I see commonly with people with early psychosis in crisis settings is that they might receive the full dose of the as needed medication, which is often highly sedating and not necessary from an efficacy standpoint. So I often encourage our clinicians to adjust the as needed medications by approximately half, especially if someone has never been prescribed an antipsychotic.
Those are great tips. All right, another situation that I know is in your wheelhouse, Rob, is we see people who come in with long-acting injectable medications in the crisis setting. What about the role of those in crisis?
Yeah, and for long-acting injectables, I think we can think about it in two ways. So we can think about when somebody's already on a long-acting injectable, or if you're considering initiating a long-acting injectable for someone. And the ways that we think about long-acting injectables often have a really important role in the treatment process. I like to think that LAIs are simply another option that people can choose if it's more convenient for them or if it's more preferable. They should not be thought of as a last resort, or they should not be used punitively if someone hasn't been taking medication consistently. The evidence for LAIs is nicely summed up in a webinar by Dr. Leon Raven, which is going to be in the chat here. So in the crisis setting, maybe we can talk a little bit more about the idea if somebody is on a long-acting injectable already. So there's a lot of long-acting injectable antipsychotic medications out there now, and the injection interval can range between 2 weeks for risperidone microspheres to up to 6 months for Invega Hafera. So a knowledge of the specific medication and its pharmacokinetics might help you to understand, especially if the medication might be wearing off in a person's system, or if someone might be having breakthrough symptoms despite being on a long-acting injectable already. So I want to talk a little bit about this idea of breakthrough symptoms, and if somebody's on a long-acting injectable, there's several things to kind of consider. So one is you want to consider all the causes that someone could be having breakthrough symptoms before you do anything. So you want to rule out medical causes. You want to consider substances if that's an issue for someone. You want to evaluate for new or changes in psychosocial stressors or any kind of changes in someone's social setting. And then if all of those have been ruled out, you can consider a couple things. You could consider increasing or optimizing the dose of the long-acting injectable. And then there's some off-label strategies like reducing the injection interval or supplementing with oral doses of the same antipsychotic medication. So for a good discussion around addressing breakthrough symptoms, we have a great virtual forum in SMI Advisor, which we're going to drop in the chat here, which you can check out. So a lot of times what happens too in the crisis setting is prescribers might be in a situation where they need to consider administering an LAI maybe early or what to do if an injection is given late. And we've collated some helpful guidance for clinicians if someone misses a maintenance dose of an LAI, which we're also going to drop here in the chat.
So what kinds of guidance would you give if you're considering starting in a long-acting injectable with others, elements that you need to approach, Rob?
Yeah, I think the crisis setting can be an important place to identify someone who may benefit from an LAI. I think that again, the conversation is really important about it. So when you think about that, some of the key components are, thinking about how do you conceptualize LAIs personally, and do you have biases about them, about who you may offer them to? And then sort of other than that, you can always present various options to the individual, including oral medications, long-acting injectable medications, taking a flexible approach. You can kind of sit down with someone and create a pro-con matrix. And then there's a nice approach called the GAIN model, which is described in the literature, which is an acronym for G for goal setting, A for action planning, I for initiating treatment, and N for nurturing motivation. So we actually had done a webinar on SMI Advisor about how do you offer a long-acting injectable to someone in a recovery-oriented way, and that link is found in the chat. And furthermore, there's actually a lot of really great resources on LAIs at the SMI Advisor LAI Center of Excellence.
How about clozapine?
Well, I'm really glad you asked about clozapine. So I think a couple things about clozapine. Despite a quarter of individuals with schizophrenia experiencing what's called treatment-resistant schizophrenia, which is really poorly named, that just means that people have not really responded to 2 or more previous antipsychotic trials and they have continued symptoms. So despite a quarter of people with this condition, only 4 to 5% of people in the United States with schizophrenia are actually prescribed clozapine. So it's highly underutilized. And what we know is that it can be a game changer for some individuals who are suffering with persistent symptoms of the illness, and it can be life-saving for others. So we have a ton of resources about clozapine in the SMI Advisor Clozapine Center of Excellence, and we have educational content, webinars, and an active listserv. So similar to LAIs, there's sort of 2 situations in the crisis setting where clozapine would come up. One is for people who are already taking clozapine, and then 2 is for people who you might think of could be a clozapine candidate. And having a sense in your local setting about who are the clozapine providers in your area, or if there's clozapine clinics around, can be really helpful. Since one of the challenges with clozapine is the inpatient to outpatient transitions. That can be a reason for hesitation on the inpatient unit, and it can be a situation where things can fall through the cracks for people. So, maybe we can talk about what happens, like if you're in a crisis setting and someone is already on clozapine. One of the things that comes up in our setting a lot is that someone might have an interruption of clozapine due to various factors. For example, not being able to get it from the pharmacy. And that can be one of the reasons why people present in crisis, because just a few days of not taking the medication can lead to an exacerbation in symptoms or other medical issues like an anticholinergic withdrawal. So cholinergic rebound is a common thing that you can see with people who stop clozapine abruptly. And symptoms of that can include insomnia, anxiety, nausea, diarrhea, delirium, altered mental status, and we even have seen people develop catatonia. So identification of these symptoms is really important, and considering adding rescue anticholinergic medications in the crisis setting can be helpful. So the other kind of thing to think about is how do you retitrate clozapine in the crisis setting for people who have missed a couple of days? And this is the number 1 question that people ask me in our setting. So the US package insert recommends that for people who have had 2 or more days of missed clozapine, it's actually recommended to reinitiate 12.5 milligrams once or twice daily. So it's a very, very low dose. And this puts prescribers in a tricky situation because this is often a subtherapeutic dose for folks. And the longer that people are on that very low dose, the greater likelihood is of symptom exacerbation. So That's sort of one consideration. The other thing in the crisis setting is to consider drug-drug interactions, which can affect pharmacokinetic issues for people who take clozapine. So as we know, one of the big ones is smoking, and smoking can affect clozapine levels. So if someone decides to stop smoking abruptly, or if someone goes from smoking, maybe a pack of cigarettes a day to a non-smoking crisis facility, it can have an impact on clozapine levels. And essentially, if someone stops smoking abruptly, the level of clozapine increases in the system because smoking actually causes the enzymes that break clozapine down to get kind of ramped up. So one of the things that we've really stressed to crisis teams in our setting is, if you can obtain a clozapine level when somebody comes in, and although there can be a delay in getting that information back, sometimes it's 5 to 7 days, it can really help the inpatient team or the outpatient team kind of put the pieces together and do a little bit of detective work about what happened.
That's great information, Rob. I appreciate you going through all that. What about in terms of as a provider, if I'm trying to identify someone that might be a candidate for clozapine, what are some ideas of information that you could share that I could share with that guest in support of information?
Yeah, so I think that providers in crisis settings often have a really unique vantage point to identify clozapine candidates. So as we know, there's 2 main FDA indications for clozapine in the United States. One is treatment-resistant schizophrenia, and then the other one is a reduction in the risk of suicidal behavior in people with schizophrenia or schizoaffective disorder. The vast majority of the people in the United States are prescribed clozapine for that indication number 1, not indication number 2. But people in crisis settings can really help to identify both of these things, and especially identifying individuals with suicidal thoughts, even despite taking medications. Those people can be, a clozapine candidate, and that discussion can be very important. So I think that even noting it in the electronic medical record or on the chart that this person may benefit from clozapine, that might actually prompt an inpatient team to start it. So it's not like it necessarily needs to be initiated and you have to do the whole thing. All you have to do is perhaps connect someone to, or just make the recommendation, begin to discuss it with someone. So pharmacology, I think in the crisis setting can be challenging. So we have a consultation service that's available through SMI Advisor where people can reach out to us. We have a number of experts in various areas. And we have a free of charge service. And if somebody has a question or a consultation, we'll get back to them within 24 business hours with an evidence-based response.
That's great, Rob. These links and resources are going to be a valuable tool to be shared. Thank you so much. I think we're ready for the roundtable.
That sounds great. So you guys really jam-packed a lot of details and information in there. There are a couple questions in the chat, but I want to turn to the roundtable first, and then we'll go back if it doesn't get covered in the roundtable and hopefully be able to address a couple specific questions. So I'm inviting to the front now Dr. Shoyinka, who's the CMO of the Department of Behavioral Health and Intellectual Disability Services. And I love the fact that you capitalized the A in disability for Philadelphia. And also, we're also inviting Dr. Deegan up to the front, psychologist and advocate, and founder of Pat Deegan and Associates, very active on LinkedIn, and really happy to have the 2 of you today to discuss with us this idea of medication during crisis services. And this might get a little heated. I'm kind of looking forward to the discussion. So take it away.
Well, I'll get started.
Sounds good.
I'm a person who was diagnosed with schizophrenia as a teenager and have seen my share of crisis services over the years. And, I agree with many of the principles that were being, espoused here earlier. But I also think that in reality, during crisis situations, people do not, or psychiatric care providers do not have the time to carefully titrate and evaluate the effectiveness of medications. And what ends up happening at the level of the lived experience, because of the time factor that's involved, is we end up from the lived experience receiving too much and very often too many different medications we leave the inpatient unit, we leave the crisis stabilization unit, whatever the facility might be, feeling, frankly, like a toxic waste dump. And immediately, once we're out, our primary objective is to get off these drugs. And I think that it's a profoundly disempowering experience for many of us. And we see that revolving door get set up over and over and over again, with moving much too fast, with too many and too much medication for people coming out of crisis stabilization situations. And I think what I am in favor with is what I call medication empowerment. I have been working on this approach for some time and believe that it is possible to work with people around discovering a much more empowered approach to using medication to support me in getting the life I want. And that becomes the focus of the work. And as was stated, it involves more than collaboration. It involves shared decision-making. There's a profound ethical imperative given the benefit and risk ratio, particularly of antipsychotic drugs and mood stabilizing drugs, et cetera, to involve individuals in having a voice and a choice in the medications that they are choosing to use or to not use. And for that, we need well-developed, empirically established decision aids, which help in plain language people understand how this medicine can help me, and also how this medication may present a risk for me, that it is not okay to assume that developing tardive dyskinesia or developing an ocular gyrate crisis, although it is very often temporary, or developing diabetes or a 40-pound weight gain is more acceptable than struggling with my psychiatric challenges. And so I'm a big believer in doing everything we can do within a crisis setting to empower individuals through an approach that I'm calling medication empowerment. First, recognize that medicine can be what we do, and it's not just what we take. That exercise is a powerful antidepressant, right? And so one of the first things we need to do in the crisis situation is to ask individuals, what do you already know how to do that helps? Because very often what gets seen as our symptoms are actually an effort to be adaptive. I use an example of myself where when I was I was in high school and experiencing my first episode of psychosis, I kept telling people, no, I'm not going crazy. They put LSD, they put a hallucinogen in my soda, and that's what's going on. Now, that was interpreted as delusional, but in fact, it was a highly adaptive strategy, because all of us know that when we're going through something that's really taxing us and really difficult, that knowing it has a time limit gives you hope to persevere through it. And that's how I was using it, but nobody took the time to ask me about that. So we need to impress on people medicine can be what we do, not just what we take, and that finding the right balance between a pill I may use and what I do to be well is a pathway into the life I want for many of us. Secondly, every single time we consider prescribing a medication for people, we first want people to craft what I call a power statement. And a power statement is basically a simple formula. It says, doctor, I want you to help me blank so that I can blank. Doctor, I want you to help me focus on being a good mom to my baby so that I can avoid having the authorities come and take my child away. I want you to help me focus. I want you to help me find a medicine that helps me wake up in the morning and have some energy so that I can go to school. Then in that formula, the N of 1 metric becomes, that N of 1 study becomes, is this person getting back to school? Are they able to take the steps they need? In other words, I've identified a personalized outcome that matters to me. That's how I know medicine is working. Not because it has, quote, depressed or suppressed a certain symptom profile. No, I know it's working because it empowers me to do something that I want to do with my life. Establishing that as the goal of care is an absolute prerequisite for buy-in into using meds to help me get the life I want. So I'll stop there.
Dr. Deegan, let me say just how very much I appreciate your comments. I think they're absolutely on, they're extremely well made. And I think that your perspective is one that we need to hear as providers much more regularly. I'll just frame my comments by saying I not only work in this administrative leadership policy role for the city of Philadelphia, but also I work as I actually provide direct services in a crisis center a couple of times a month. So I'm familiar with both the system level, population level concerns that you've raised, but also the perspective of actually having continue to work in this area. And I'll speak from both those perspectives. So the first thing I'll say again is I have no, I mean, I think all the things you've said are absolutely on target. We certainly, as providers, I think need to, so let me actually say this. Context matters, right? In the crisis center, the crisis stabilization level of care would be probably equivalent, I think, to the intent to being in an ICU medically. As you rightly said, those are very fast-paced settings where the goal initially is to just stabilize the situation. And as you rightly mentioned, there often historically has not been attention paid to the needs of the individual. I'm pleased to say that Philadelphia has taken a different tack over the years. And one of the signature, I think, accomplishments of the system here has been to move to a recovery-oriented system of care in which peers are embedded all the way through the system, including actually working at the county office, which is where I work. Now, just to respond to a couple of things that you mentioned, I could not agree more with the idea of stating things in plain language, certainly engaging people in conversations. One idea that may capture some of what you've shared is the idea of advanced directives, which the state of Pennsylvania had spent a lot of time putting together over the last about 7 or 8 years. Now, implementing that and making it operational at on a system level is quite a task, I'll tell you. But the basic essence of that, I think, the basic essence of the advanced directive is to reflect individuals' wishes, including choices of medications, including choices of just engagement strategies, how a person even wants to be talked to in that very oftentimes chaotic, painful situation that they're in at that point. And so I think the idea of advanced directives is one that deserves revisiting. One other thing that I will mention is we focused our conversation a lot on medication, as it should. It's one of our big tools. A couple of thoughts I'll add. One is that as we've begun to rebuild expand our adult crisis system in Philadelphia, our team has taken a very, very much of a learning approach. Specifically, we have engaged the Family Advocates network that serves the public mental health system. And that group has been involved in every level of our crisis rebuild, including designing thinking about how mobile teams should operate, including how people should be engaged, including what should happen when people if they have to go to the CRCs, how they actually engaged at the CRC, at the crisis response centers. And that work is ongoing. I think at some level, it boils down to culture change. I do agree that there's a need for more dialogue. There's certainly a need for services in a less restricted fashion and at less restrictive levels of care. And I'll just stop there.
Thank you both, Dr. Deegan, Dr. Shoyinka. Thank you also for the conversation going on in the chat. I think, one of the most powerful lines, and I could see it being a quote in the coming weeks, is there are always two experts in the room. There is the individual who's there, who's seeking assistance, and there's the individual who brings their knowledge from their education. But both of them have to listen to each other, and we all need to do shared decision making a lot better than we have been doing, and have mutual respect for each person's expertise that they bring to that conversation. As just was written in the chat, voice and choice, very good. So let me move on to the crisis trivia hot seat. I'm always happy to be the moderator and not in the hot seat, but I'm happy to invite Debbie Plotnick forward today, who's offered to be in the hot seat. She's the Executive Vice President for State and Federal Advocacy at MHA. And Debbie, welcome to the hot seat.
Thank you, Amy. It's my pleasure to be here today. And I have to smile because how can somebody from Mental Health America not smile when Clifford Beers, the founder that we trace Mental Health America back to, appears in the answer?
I know. Wonder how that happened. So remember that you can phone a friend. We're gonna give you the audience reaction. So let me read the question. And I think very relevant to what we talked about today. The peer movement's roots can be traced back to many pioneers. One of the earliest hired those with lived experience because they were, quote, disposed to kindness. So who was the earliest peer supports innovator of the list below? Number one, or A, Bill Wilson, also known as Bill W. of Alcoholics Anonymous. Jean-Baptiste Poussin, hospital superintendent. Clifford Beers, National Committee for Mental Hygiene, beginning of MHA, and Dr. Harry Stack Sullivan, also a hospital manager. So first, Debbie, we're going to get the audience reaction to see if we can give you some help. Just a couple seconds here, and we'll show you the results, see if it helps at all. Hopefully we haven't split the audience. Hopefully there'll be a clear answer here. Oh, maybe not perfectly helpful. Looks like not very many people went with D, but there was a good A, B, and C split. I don't know if you want to go with what they said, if you want to phone a friend, if you want to just go with your own answer. What do you think?
Well, Amy, while I smiled at Clifford Beers, Clifford Beers did not hire people. Clifford Beers spoke about the importance of lived experience and people fighting in the open. So I'm not going to choose Clifford Beers as the answer. I believe it's Jean-Baptiste Poussin.
Okay, so you're going with B, final answer?
Yes.
You were right. Woo-hoo! So let me just say a few things about Jean-Baptiste Poussin. He was a hospital superintendent, worked with his wife Marguerite in the 19th century French hospitals, but really paired with a couple key patients to begin to move through what patients wanted and to listen to their expertise. And one of the big things he's known for is getting rid of restraints, actually chains that were used, both at the hospital that he started at and then at the hospital he moved to afterwards. And it became known as moral treatment, where he began. And so congratulations, Debbie. I know that David Covington will not be happy that he did such a good job splitting the audience, but that you were still able to persevere. So congratulations, and thank you again for being on the hot seat today.
Thank you, Amy. I just
Next
want
slide.
to say This is the anniversary of the mental health bell, that what is the symbol of Mental Health America, that was cast from the shackles and chains collected all around the country. So please check out our website to see more, to see the Bell of Hope, as we call it. And thank you for allowing me to be here today.
Wonderful. Yes, wonderful. Thank you so much. Next slide. So move into the data corner, and for those of you who are regular JAM participants, we moved the data corner up today to give a little bit more room and to highlight the data corner a little bit more. And so we are pleased to have pleased to have Dr. Deb Peinels here with us today to talk through a little bit about data and crisis services. So Deb, take it away.
All right, well, great. Thanks for inviting me. Great to be here. I love that we got to hear about the mental health bell, and this is the perfect time to hear it as we're moving into May. And I love the discussion about medication. So awesome, awesome job, everybody. So my job today is to tell you a little bit about preview of coming attractions with regard to data and crisis services. This is a real area of need as we grow crisis services in a lot of different directions. Many of us are hungering for models to use and answers about what might work and what's working and what's happening out there. So the National Association of State Mental Health Program Directors, or NASHBID, and the NASHBID Research Institute are partnering, working on 3 upcoming crisis services data reports that you will be interested to see. The first is a technical assistance collaborative paper on how 12 states with comprehensive crisis systems are using data across their crisis continuum. And that will be highlighted in a 2-part webinar that's coming up in May on these TAC paper findings. And they're going to highlight Georgia, Tennessee, and Utah, each in various stages of development with different areas to highlight. But they'll be able to share examples of their data collection tools, dashboards, and people will be able to actually see what these dashboards are looking like that these states are using to manage their crisis systems. In addition, there's going to be a state profiles report, which I, really rely upon in my role in Michigan as the state medical director, looking at these state profile reports, which are ways to get state leaders to answer many questions and then tell the rest of us what's happening around the country. And so the 2022 state profiles component report will focus specifically on crisis services. And I was reviewing some of the questions today. I think you're going to see a lot of things about, what's happening with your crisis call centers, what's happening in states with regard to mobile crisis and separate or together with kids, mobile crisis intervention, stabilization services. And so I think we'll get a lot of answers once that survey is distributed and then the answers are collated. Next slide. In addition, just to go into a little bit more, I talked about the crisis call centers and the mobile crisis teams, but a lot of discussion and survey data will come forth about 24-hour crisis stabilization centers. And then questions are being asked about crisis residential programs, which are defined in this particular survey as anything 2 days to 14 days, whereas the crisis stabilization centers are defined as 24 hours or less. And so that'll be very interesting to see how states that are surveyed respond to how they're building out these different component parts. There's lots of other data that's coming out through the state mental health authorities as they are building out data collection and technology issues that are being used to support the crisis continuum. The survey is going to cover transportation for clients needing crisis services, which will be really helpful. That's something I was just in meetings about in Michigan just the other day about how we're going to think about transportation needs. And then also the survey will look at building, sustaining, and training on workforce. No doubt workforce will be one of the issues that comes up for everybody, I'm sure, that's answering this in terms of how do we recruit and sustain a qualified workforce in this space. And with that, I'm going to turn this over to my colleague, Dr. Goldman.
Hi, everyone. Thank you so much. I realized I got the date wrong on here, forgot to update it from last month. But just really quickly, a couple data bites as part of our monthly Data Corner feature. First, wanted to highlight the work by Jonathan Pirtle and his colleagues. They wrote a paper in JAMA Health Forum on earmarking excise taxes on recreational cannabis for investments in mental health and underused financing strategy. And in this paper, which I'm putting the link in the chat right now, they mention that crisis services are a potential type of mental health services that could benefit from cannabis-related excise tax funding. So a very interesting article that I encourage you guys to read. Otherwise, to highlight a couple research funding opportunities. So the NIMH has now put out 2 notices of special interest that are highly relevant to researchers that are interested in expanding the evidence base on crisis services. One is a priority research on priority research opportunities specifically in crisis response services. And the other is research using implementation science on the delivery of evidence-based practices in community mental health or general medical healthcare settings. And they highlight in particular CCBHCs as a setting in which research for this special notice could be conducted. And they also emphasize crisis services as part of CCBHCs as being of particular interest. So just wanted to highlight those for everyone, and I'll post those additional links in the chat as well.
Right, and people actually just asked, please post those links. So thank you for Dr. Goldman, Dr. Pinels today. I'm so happy that the Data Corner moved up a little bit. It was good to hear from both of you. I want to just point the audience to a wonderful interview that Steph Hepburn did with Dr. Deegan. You heard from her earlier today, but I really encourage you to check out this interview for even more information and in-depth thoughts about integrating medication and recovery concepts in crisis care. Next slide. I'm sorry, my screen might be a little slow. On to SAMHSA. So I wanted to ask John Palmieri to step forward and let us know what's going on with SAMHSA.
Thanks, Amy. Thanks, everyone. Happy to be here. So just very quickly, a couple of updates and announcements. One is that we're happy to announce that the funding announcements for the state and territory 988 grants are forthcoming at the end of this week. There's been a lot of hard work on the team put into that, and really pleased to be able to lean into that partnership with states and territories to support capacity building at the local level with respect to crisis response. Also want to note that even though we have historically been referring to ourselves as the 988 team, there is movement to actually recognize us as an office. So both in terms of the omnibus appropriations and in terms of our friends at HHS, there has been more formal recognition of the 988 coordinating office within SAMHSA in the Office of the Assistant Secretary. And so that is huge progress, and I think really speaks to the importance that the administration is placing on this activity. So on these activities. So really happy to report on that. I am going to throw a couple of things in the chat that really are related to some updates regarding financing and partnership with CMS. I think I might have inadvertently thrown one in there a little bit earlier, but I'll do it again, which again is a partnership engagement that we're working on with CMS to really support guidance around funding of crisis services. And so there's a PowerPoint that I'm gonna send that includes some information on the administrative claiming option for crisis centers, which I know is something that people have had lots of questions about. And then also a report out from the January convening that happened with CMS on financing crisis services. And I think in the interest of time, I'm going to stop there. Richard, did you want to add anything?
Wonderful.
I would just add that, as some of you may be aware, SAMHSA was given $10 million for mobile crisis services. And so the 988 office and CMHS are working collaboratively to develop a funding announcement for that $10 million. So we will you'll be hearing more in the not too distant future.
Wonderful. Well, thank you both, Richard and John, from your office, not just your team. Thrilled for you for that recognition. Next, we'll turn to Megan from Nashville.
Hi, everybody. I just wanted to announce one thing. You can see on this slide, there's a 988 resource site that's from NASHBID. And on that resource site, it includes also NASHBID recommendations for effective communication, planning, and response with deaf communities for 988. So I just wanted to draw your attention to that. It's a great resource and answers a lot of questions about why would ASL fluent counselors be important rather than interpreters, by having a national center for crisis and 988 for people who are deaf is more advantageous than having just state-run crisis services for people who are deaf. So I just wanted to note that, and hope it's a great resource for you. I'll put it in the chat. I'm going to turn this over to Arlene Stevenson on NASHBID staff who about 988 FAQs. Arlene.
Thanks, Megan. I wanted to introduce you to our new FAQs on 988, and we've entitled it A Small Price to Pay for Strengthening Suicide Prevention, Crisis Response, and Care. And our intended audience really is the legislators in this case. The purpose of the FAQs is to try to ratchet down the opposition to the phone bill fee that would finance 988 and the related crisis services. So the facts start with what is 988 and what happens when you call. We've taken the opportunity to use some of NAMI's survey data to address public opinion issues about mental health services, because that's something we know legislators care about. And we discussed why 988 is better than 911 for crisis context. Get more appropriate care, the responders are behavioral health professionals and peers. The response teams are only dispatched 2% of the time. You know, imagine the savings with that. And it reduces the probability of jail time. We hear from legislators still on why didn't we use another 911 type number like 811 or 711. And so we explain that in this facts. And our main purpose really was to get at the concerns of the telecom industry. And so we've taken the time, because it's important to clarify that the expense is the customer's expense. It's not a new expense on the telecom provider. That the fees are small. If you look across the states, it only ranges from 8 cents to 75 cents in terms of what's been proposed in legislation. And we also took the position to agree with the industry that states should be transparent on fee calculations. That's something that the industry has been complaining about. The facts end with a response to the naysayers using some powerful quotes. One from Senators Wyden, Merkley, and Murphy, who wrote a letter to the Industry Association, TICA. One from AT&T, who explained that they want to be part of the solution. So they're a provider. And also my favorite, which is from the executive vice president of T-Mobile and their actions. They jumped on the implementation of 988 months ago and have made it available through their system. So that's a must read. This is a great tool to leave with a legislative office if you don't have the opportunity to talk to someone. And it's available now on the NASHBID website under What's New. I wanted to thank Christy Malik and Jane Tobler on our staff for their help with this, and also our collaborators, Laura and Matt from the Vibrant staff. Sorry, losing my voice. And as you see, we have a coming soon. Hopefully we'll tell you about this next time, which is the state options and choices in financing 988 and crisis services systems.
Thank you so much, Arlene. We just are thrilled with this new FAQ. Moving on to Joanna Rosen from AFSP.
Hi, yeah, so I have just a couple quick federal updates, and I will try to be very brief because I am aware that we're running out of time. But last week we saw the House Energy and Commerce hearing on mental health with Assistant Secretary Dr. Delphin Rittman and HRSA Administrator Carol Johnson testifying. They did mention 988, the need for more funding, and focus was highlighted, so that was really encouraging to see. And then also I dropped in the chat just a couple seconds ago a dear colleague letter from Senator Reed's office. It's going to be circulating through Congress for the FY23 budget, highlighting suicide prevention needs, and they do highlight 988 as a need. So if you want to reach out to your senators to get them to sign on, that would be great. Just again, I dropped that in the chat a couple seconds ago. Please take a look if you're interested and if you can, but I'll turn it back because I know we're running out of time.
Thank you so much. Quick update from Jordan Pantalone from Vibrant or Steph Pasternak from NAMI.
Yeah, thanks so much, Amy. I'll just make this very brief. The big update in the last week is New York. New York passed their budget. They appropriated $35 million for 988 implementation. And as part of that budget package, they included some 988 legislation based on the Model 988 legislation. So that's really the big update this week in the interest of time. That's all I'll say. Thank you.
So as you know, we have a number of state cards that we have. I wanted to move to the very end and just show you what's coming up because you're going to be excited. So I think next week is just going to be amazing. Lessons for 988 from poison control. That's going to be terrific. Then we're going to hear from the new office, SAMHSA's new office on 988. And then look down this list, just some amazing speakers and topics coming up. I thank all of you for joining us today. Have a wonderful week, and I'll see you next week on Wednesday. Bye-bye, everyone.